Hi everyone. In week 6 we're talking about social work within a health context. So today's lecture will cover some of the history in terms of health and social work, as well as having a look at what contemporary social work practice looks like within health settings. So your prescribed reading for this topic is textbook chapter 14, which is Contemporary Issues in Health Social Work. There are also 2 additional readings for this topic, which are within your learning modules and also links within this page. Just a really quick overview of the sort of things that I'll be speaking about in lecture today. We'll be looking at the origins of social work practice in health. We'll be looking at objectives and methods of social work in healthcare settings, talking a little bit around the medical model, as well as chronic care and the biopsychosocial model, as well as talking on the shift to primary healthcare approach. I've popped a short little YouTube in here that provides an overview of contemporary social work in a health setting, so please watch that at your own leisure. In terms of a general background, the first known hospitals were places of rest, of care and prayer, rather than places of treatment and cure. The nursing profession emerges from this tradition, and the medical profession emerged later and gained power as medical knowledge advanced. So sort of just setting the scene here in where we come in as social workers within a health setting. Again, on the origins of social work and health in the UK, as you know from the other lectures, we cover some of the history from the UK and the US, as they were really pioneers in the field of social work prior to it becoming a profession here in Australia. So the origins of social work and health in the UK really originate from the almshouses, which provided aid to the poor, and they were really the forerunners of free hospitals and sort of public health care, I guess. In 1891, the UK House of Lords submission put almoners in hospitals to determine those eligible for free treatment. The almoners were really the gatekeepers in a lot of ways for free treatment at charitable hospitals, and they were the go-to person if you're a patient there. The USA had really similar early development to the UK in terms of social work practice in health settings. Between 1889 and 1903 within the US, we saw an increase in the use of social workers in hospitals in many different forms, but one of the primary ones was a visiting service to lone mothers and stronger links between community and hospital. Again, some minimum practice standards were developed in the early 1900s. And post-World War II, we really saw an increased use of sociological concepts in the work that these workers were undertaking, which underpins a social work approach to health in a contemporary setting. A little bit more on the almoner's duties. I was trying to find some pictures to share here, but I guess there's not a lot, and we've got to be really aware of creative license and that sort of thing, and copyright, so sorry I haven't got anything overly interesting, but their job roles really included preventing the abuse of free treatment. So like I said, they were the gatekeepers. They were there to ensure that free treatment wasn't overutilised or wasn't given out unfairly. And you can sort of see their role and what it may have looked like. They made referrals to the poor law authorities, and they also mobilised other resources to help the poor and aimed to increase the effectiveness of treatment and interviewed patients and encouraged thrift as well, which I think is a really interesting point. Within the Australian context, the training of almoners, which were the hospital social workers, varied from state to state. The earliest training started in Melbourne and Sydney in the late 1920s, and it was based on the UK model at this time. Throughout the 50s and 60s, we saw a lot of change in social work in general, as you know from the first couple of lectures, but as well as for social work in health. We saw a greater emphasis on group work. We saw this a lot within the US psych wards and running groups with mental health and that sort of thing. We saw an increased recognition of social control issues during this time, more social work input into social policy, more social activism and proactivity, and less dependence on referrals from medical staff to social work. So I'll talk a little bit about that further on when I talk about the medical model of practice, and an increased focus on prevention, community and advocacy as well. So not very far along at all, sorry. So this is when I referred to less need for referrals, I was alluding to the medical model of practice within health, or the acute care model. So this model really has quite a hierarchy, a medical hierarchy, where the medical doctor is seen as expert and is responsible for diagnosis, treatment and outcome, and the patient's seen more as a passive and compliant with the medical doctor's orders. There's a focus on the mechanics of the body in this model, as well as individualised treatment of symptoms, often quite pathologised as well. Again, the doctor's seen as the expert in diagnoses, in prescription and in treatment. A little bit repetitive there, I've just noticed, sorry. And it really speaks to the hierarchical organisation of hospitals, which we can still see currently. There tends to be, in terms of staffing within hospitals, quite a hierarchy. And I'm sure many of you are aware of where social work may sit there. Outcomes are measurable and scientific within the medical or acute care model. They're not grey or airy-fairy. Their outcomes are quite evident. So what role do we play as social workers within this medical model? Already it seems to sit quite at odds with our ways of working and our ways of thinking about things. But we all of our, as the social workers who work within our hospital setting per se, or another medical setting, do work within the model. So part of the role is to respond to referrals. So be reactive rather than proactive in seeking clients to work with, working towards discharge planning and practical assistance. So you'll find social workers within a hospital setting doing a wide gamut of roles, depending of course on the area that you're in, or how big the social work department is in your hospital. I know many city hospitals have huge teams of social workers and social work teams within each separate department, whereas I know that in more rural communities, the hospital may not even have a social worker, or if they do, that social worker is responsible for all facets of social work interventions within the hospital. So already you can see how the role would be quite different depending on the context and the medical field where you're employed. So, as I mentioned, social work does find itself at odds with medicine, in that its central belief is in respect for the client's self-knowledge and right to choice. Within the first assessment, you talk about the values and the ethics of social work, and the things around empowerment and social justice, and it just seems a little bit at odds that within the medical model, when the client is quite passive and does not have a lot of say in their treatment or their care. Medical expectations of patient passivity fit uneasily with social work objectives and of self-directed and empowered clientele. So sorry, that quote down there, really encapsulates the thinking there. Not to say that we don't work within this model, or that we can't work really effectively within this model. Many of us do. It's just something to be really aware of when we're thinking about working in a model that is sometimes at odds with our professional ethics. So changing contexts and paradigms in health. There's of course, as with all fields, an increased use of technology these days, pharmaceuticals and demographic change. We've got an ageing population, and of course within a health setting that has significant impacts. Escalating costs in healthcare provision, and a real need to decrease government spending on health but to maintain quality. And I'm sure you have all been really aware of conversations around that, or things in the media speaking to the fact that there's less money, we can't do what we were once doing, and we need to somehow maintain quality, and what that looks like. There's now also more of an emphasis on early detection, prevention and screening, and primary healthcare models as well. Healthcare reform. So, I mean, I've labelled this slide healthcare reform, but as you can see, my content's from 1995, and it came out of the COAG, the Council of Australian Governments meeting, and Foundations for Current Health Funding Sector. And it was really looking at key reform objectives. 95 now, that's how many years ago is that? I'm really shocking at maths. 25 years? Oh, no, I'm not even going to try, sorry. It's a while ago though, and the interesting thing is that there hasn't been a lot in terms of government level healthcare reform across the nation since that time. There's obviously been a number of small reforms and funding and policy and that sort of thing, but nothing huge. So these reforms and this report really speaks to sorry, a move away from institution-based funding in health, an encouragement of health promotion, prevention and recognition of the multidimensional nature of health, changing views of patients to consumers within the sector, decreased reliance on medical services and more reliance on allied health professionals, increased service integration, multidisciplinary teams, increased recognition of the biopsychosocial nature of health, which really fits quite well with a social work perspective, and also the need for a team approach. So, I mean, I'd like you to reflect on these points. This was a while ago now, and is this something that is happening within the sector, or is this something that we just thought was the norm, or are these things still not happening? Some really interesting things to think about. More contemporary resource probably is the Australian Healthcare Reform Alliance. So ACRA has played a really significant role in advocating for healthcare reform within this country, and it's actively worked to influence the development and implementation of a health reform agenda. So following sort of the healthcare reforms I spoke about on the last slide, there was within government the establishment of some groups to guide government in terms of what was needed in healthcare reform. However, these groups did not continue long term, and ACRA really formed as they saw a gap, and they thought, well, look, all of this money and all of this expenditure is going to our hospitals, but really we need to be looking at it from a different perspective. We need to look at health in a new light, in a new way, and there needs to be a lot of reform within this sector. I think the stats at that time were that we had sort of the highest one night stay rate in hospital of all developed countries, and shocking things like that. So ACRA really play an important role in healthcare reform. They meet regularly with key federal politicians to advocate for health system reform, provide input into relevant inquiries and reviews, make public comments, hold summits, developing policy and discussion papers, and also partner with other key groups. Okay, so just moving on a little bit from healthcare reform, but really interlinked, because if you think back to some of the reforms that were suggested in 1995, one of them was that we work in a way that's more a biopsychosocial approach. And that's where we see the emergence of the chronic care model. It recognises the multidimensional nature of health, and therefore the need for a multidisciplinary approach. It seems really self-evident. Health is multidimensional, and of course, with many health issues, you need to have that multidisciplinary approach in there. So when I talk about multidisciplinary approach, I'm talking about having doctors, having OTs, having social workers, having psychologists, having everyone involved in order for the consumer to reach optimal levels of health. The chronic care model is more community and context orientated, and social work moves away from individual casework in the chronic care model to focus on case management model, and patients become participants. So that really person-centered approach there as well as a consolidation of community healthcare approach and roles for social workers and community health centres. So, I mean, many of you would have noted the rollout of the chronic care model over the last 10, 20 years and seen a little bit of a difference in the establishment of these more community and case management based services. So social workers provide a framework for practice that's unique. Their skills provide psychological support to clients and families, creating a facilitative climate in which they can adjust to the psychological impact of the physical, mental condition on themselves and their families, as well as guiding them on practical issues. So I think that quote really encapsulates the way in which social work practice is quite distinct from the medical model. If we think back to the slides on the medical model is really looking at diagnosing a problem and fixing that problem, whereas a social work approach is having a look at everything else around that client and what's happening for them at the time. So social workers in health. Social workers in health currently provide services within hospital settings, as well as community primary health settings, and a number of other areas within health as well, probably too many to list. Social workers in health often undertake social work assessment of service users' circumstances. These assessments are generally your biopsychosocial type assessment or multidimensional assessment, so an assessment on the whole person. Social workers in health provide support for carers. They locate relevant sources of support in the community, formal and informal, completing referrals for clients, advocacy, health promotion, research, policy and evaluation. So, I mean, the ways in which social workers provide service in health is really multifaceted and quite varied. Our locus of interventions within health are at an individual, family, group, community, organisation, policy and research level. So as you can see, social work covers sort of the whole gamut of intervention levels within a health setting. Our modes of practice. So if you think back to the first lecture, it really links in well with a lot of the modes of practice with social work as a whole. You'll find that health social work crosses over all of the different modes. So your casework, your group work, your family therapy, community development, education, health promotion, research and policy. I've popped in here just a really brief, not the entire thing, job description for a hospital social worker. And this is a social work grade 2 at a major Melbourne hospital. And I think from what you can see from these skills that are listed as required, there is just a huge range of skills required to successfully undertake this particular role. And I think when we think about social work and health, it is so multifaceted that you can't sort of go in with the one skill set. You can't go in and say, oh yes, I've got wonderful group work skills and I'm an excellent facilitator of groups. So you need to have just this huge, broad range of skills and knowledge bases. And also health generally is quite good at supporting their workers in offering extra professional development and those sort of things where needed. On this last slide here, I've just popped another couple of YouTube videos on hospital social work. So you've got two social workers here speaking about their experiences of working as a hospital social worker. I guess as closing thoughts today, I find in our local communities out in Western New South Wales that health is actually the number one employer of social workers in our towns. So whether that be through community health, through the hospitals, through the Aboriginal health services, but the health sector seems to make up a great number of our student placements, as well as work post-graduation and work in general. We have a community social work group and it's made up primarily of health-based practitioners. So it is definitely, if you're looking for a career in social work, something to really consider, a really interesting field of practice. And thank you for listening today. Bye.